completed the general pharmacology, ANS, and now started with the local anesthetics. The class has been done, local anesthetic. And now we will coming to the skeletal muscle relaxant. So we are now moving towards the central nervous system, CNS chapter. This CNS, including the skeletal muscle relaxants and local anesthetics, these are very important chapters and one of the complex chapters of the pharmacology. Okay. So after every class, you need to learn, you need to check your books, otherwise you will forget or the analysis will not be internalized into you. So today we will discuss about, this is another complex chapter, that is skeletal muscle relaxant. So what does it mean? So basically we are now today discussing about the drugs or the chapter that are relaxing the skeletal muscles. Now why it is needed, relaxing of the skeletal muscles? Basically when we are doing the anesthesia or we are doing different internal procedures like some colonoscopy or bronchoscopy, laryngoscopy or different types of the endoscopies, it will be easier if the skeletal muscles are relaxed. Or in the anesthesia, we have to perform the different surgeries, and you know that during anesthesia there are different planes. You will learn about this in general anesthetics. With higher planes, that is with deeper anesthesia, the muscles will get more relaxed. But with deeper anesthesia, there are obviously problems of again reconsciousness and several other things. So if we are using the skeletal muscle relaxants, that can help muscle relaxation if we are using this with the general anesthetic agents even in lighter planes, that is with few amount of the general anesthetics, the muscle relaxation will be more if these are combined with some skeletal muscle relaxant. This is one hand. And another hand, there are different types of the spastic conditions or diseases. For example, there may be amyotrophic lateral sclerosis or different other cerebral palsy type diseases where the muscle spasms are more. In those cases also we need the skeletal muscle relaxants. Mainly these are used the centrally acting skeletal muscle relaxants. So peripherally acting skeletal muscle relaxants are basically used, most commonly used in accordance with the general anesthetic agents to relax the muscles so that the operations or the different internal procedures will be easier. On the other hand, there are central skeletal muscle relaxants. Those are mainly used in different spastic condition or different types of the diseases. Apart from this, there are several other skeletal muscle relaxants that can be used in various conditions. For example, there is dantrolene, one agent that is used in malignant hyperthermia. Okay, we will discuss about this. So let's start. So I have already discussed, so these skeletal muscle relaxants basically what these act? They act mainly at the neuromuscular junction or the skeletal muscle fiber itself. Okay, neuromuscular junctions you have already read in the physiology, you can revise this. This is also present in the introduction chapter of the pharmacology book. So neuromuscular junctions, muscle endplate, where there is propagation of the muscle action potential, and due to the propagation of the muscle action potential, there will be contraction of the muscles. So with the skeletal muscle relaxants, we are decreasing the contraction of the muscles, we are relaxing the muscles. So this is the main. So ultimately this causes muscle tone, reduce muscle tone and or cause paralysis. So if it is given in very high doses, that can give paralysis. Most commonly flaccid paralysis happens. Already we have discussed this. So neuromuscular blockers, another part is the spasmolytics, which is the centrally acting skeletal muscle relaxants. So neuromuscular blockers mainly relax the normal muscles in surgery, assistance of the ventilation, etc. No central nervous system activity, used primarily as a part of general anesthesia. While spasmolytics or centrally acting muscle relaxants reduce spasticity, centrally acting except dantrolene, what I am discussing, used in a variety of neurological conditions. So mainly there are two types, peripherally acting, centrally acting also known as the spasmolytics, because they are decreasing the muscle spasms, and these are the different diseases. For example, Stephen Hawking is suffering from the amyotrophic lateral sclerosis. Here there happens severe muscle spasms in the early stages. So these are some examples where these spasmolytics or centrally acting muscle relaxants act, and peripherally acting muscle relaxants already we have discussed, mainly used to surgery. So this is the classification of the drugs. Now these neuromuscular blockers, this is also known as the peripherally acting muscle relaxants, what we are discussing. They can again be divided into two groups. One group is the competitive neuromuscular blocker, competitive, another name is the non-depolarizing, okay. Another is the non-competitive, its another name is the depolarizing, okay. So when the neuromuscular blocker is the competitive, another name is the non-depolarizing, and non-competitive means depolarizing. So you have to remember, this is very important. So depolarizing, non-depolarizing, two types. Depolarizing means it is non-competitive and non-depolarizing means it is competitive. So these are the examples. Non-depolarizing or competitive neuromuscular blocker, d-tubocurarine, pancuronium, vecuronium, atracurium, nevacurium. These are examples. And depolarizing or non-competitive, now only one drug is used, succinylcholine. Decametonium is not now used. So succinylcholine is the only agent that is used under the depolarizing neuromuscular blocker or non-competitive neuromuscular blocker or peripherally acting non-competitive muscle relaxant. Spasmolytics or centrally acting, it may be centrally acting, example is diazepam, chlorzoxazone, tizanidine, baclofen, there are several others like thiacalcicoside, etc. And directly acting is somewhat different, known as the dantrolene. So this is the classification. So skeletal muscle contraction, what I am saying that you have already read in the physiology. So in the neuromuscular junction, the main neurotransmitter is the acetylcholine, okay. So acetylcholine comes and ultimately it attaches with the, in the neuromuscular junction, which receptor is present? NM receptor, okay, NM receptor is present. So NM receptor is basically, it contains 5 subunits, it is a rosette-like structure. There are 2 alpha subunits, there is 1 gamma or epsilon subunits, and there is 1 delta subunits like this, 1 is beta subunit. So 5 subunits, and within this 5 subunits rosette-like structure, in the center there is sodium channel, sodium ion channel. So when the acetylcholine attaches in this channel, in this receptor, NM receptor, ultimately it causes some conformational change and the sodium channel opens so that the sodium ions can propagate and ultimately muscle action potential happens. So what happens for the competitive blockers? Competitive neuromuscular blockers means it is competing with the acetylcholine. So they are basically antagonists, and you know about the antagonist. Antagonist means they have affinity but no intrinsic activity. This is also important. So agonist means they have affinity and intrinsic activity both is present. Antagonist, affinity is present +1 and intrinsic activity is 0. And inverse agonist means affinity is +1 and intrinsic activity is -1. That is opposite. So here the competitive neuromuscular blocker is the antagonist, okay, antagonist to this NM receptor. So they are competing with the acetylcholine. So what happens, these drugs, this competitive neuromuscular blocker or non-depolarizing blocker, they are known as non-depolarizing because they are not depolarizing the NM receptors. So depolarization of the NM receptor is needed for muscle action, for the propagation of the action potential. So they are competing with the acetylcholine and they attaches with the NM receptors. Because their affinity towards the NM receptor is more than the acetylcholine molecule. So what happens, these molecules, these competitive neuromuscular blockers are bulky molecules, okay. They are bulky molecules. They are also known as the pachycurare, that is they are bulky molecules. When these bulky molecules attaches with the NM receptors, they will not cause the conformational change, so the sodium ion propagation will not happen. Acetylcholine cannot also act, so ultimately the muscle action potential cannot be propagated and ultimately muscle relaxation happens. So it is clear, in clear terms. So competitive neuromuscular blocker competes with the acetylcholine in the neuromuscular junctions to attach with the NM receptors. NM receptor is a 5 subunit rosette-like structure. In the center there is sodium ion, and when the acetylcholine attaches with this, there will be propagation of the muscle action potential due to propagation of the sodium ion. And when this competitive neuromuscular blocker blocks there, they have affinity more than the acetylcholine, so they competes and wins. Ultimately, they attaches with the NM receptor. Acetylcholine cannot attach. When they are attached, they are very bulky molecule, so the conformational changes will not happen and the sodium ion cannot be propagated, muscle action potential cannot be propagated. Similarly, when the acetylcholine level is very high, so it can somehow surmount this antagonism. So when more acetylcholine is given, so it can be surmountable. Again, it can be surmountable by another thing, acetylcholine esterases. So acetylcholine anticholine esterases. So anticholine esterases basically when we are using this, for example, neostigmine, again these molecules, this can be surmountable. That is, this blockade, this antagonism can be surmountable. So this is in clear terms about the competitive neuromuscular blocker. So this non-depolarizing or competitive depolarizing blocker, according to their half-lives, there are different types. For example, long-acting, intermediate acting and short-acting. Why this different half-lives neuromuscular blocker is needed? Because different operations need different times. So if you are doing some neurosurgery, that means approximately 6 or 8 hours of the muscle relaxation is needed. For this, a long-acting muscle relaxant is required. But again, when you are just doing some endotracheal intubation or some laryngoscopy, so we need some quick onset muscle relaxant that can be surmountable, or their actions will pass very soon. So there we need some short acting. Okay. So that's why long acting d-tubocurarine, pancuronium, intermediate acting atracurium, vecuronium, rocuronium, and short acting is mevacurium. D-tubocurarine, perhaps you have heard about this. So d-tubocurarine was previously used by the South American tribes as arrow poisons for the hunting. Okay, so it is also known as the cuirae. So you have heard about the cuirae terms. Cuirae is a arrow poison. So in the 1930s it was seen that when we are using this, it can help in the muscle relaxation. But since d-tubocurarine has different other adverse effect, it is lesser used nowadays. Newer molecules are more used nowadays. So already I have discussed this. So NM receptor 5 subunits, when it competes with this, ultimately these competitive blockers are bulky molecules, 2 or more quaternary sodium ion is there. Ultimately conformational changes will not happen and ultimately blockade happen. So the acetylcholine released from the motor nerve ending is not able to combine with its receptor to generate endplate potential. Frequency of the channel opening is reduced. Conductance of a channel, again it is compromised. Ultimately the antagonism is surmountable by increasing the concentration of acetylcholine or by anticholinesterase in vivo. So already we have discussed. So the same thing you can see. So here there is the place of the acetylcholine binding, and these neuromuscular blocking agents are basically competes with this to bind to it here, and their bulky molecule will not do conformational change, and ultimately the muscle action potential will not be propagated. They have affinity but no intrinsic activity, that is antagonism. So ultimately the muscle relaxation happens. So it is clear. Now what happens at very high concentration, when we are using these cuirae drugs in very high concentration, they can directly enter within the sodium channel, okay, and directly block them to produce more intense, and that becomes a non-competitive neuromuscular block that is only partly reversed by neostigmine. That means when we are using very high concentration of this drug, they can itself enters within the sodium channel and blocks this, and ultimately causes some non-competitive type of the blockade also. So when this non-competitive type of blockade happens with very high concentration, that cannot be surmountable by the neostigmine, that is the anticholinesterases. This may happen. The competitive, these blockers also block some pre-junctional nicotinic receptors located on motor nerve endings. So what happens when the muscle action potential happens, you know that pre-junctional these receptors are also activated so that the more quanta of the acetylcholine are released. So ultimately this will be propagated. So these agents also block these pre-junctional receptors so that the more acetylcholine release is also decreased. So the same thing, activation of these receptors by acetylcholine normally facilitates mobilization of the additional quantity of the acetylcholine from the axon to the motor nerve endings, and their blockade contributes to depression of the neuromuscular transmission. And these agents also show one phenomenon, this is known as the fade phenomenon. Fade phenomenon means twitch response. Twitch means when we are giving some impulse, that becomes contracting. This is known as the twitch. These twitch responses during partial block are progressively depressed on repetitive stimulation. So what happens when we are repeatedly stimulating this, ultimately this twitch response, that is the contraction of the muscles, gradually decreased. This is known as the fade phenomenon, and it is seen in case of the competitive or non-depolarizing blockers. So when we are using this competitive blocker, what happens in different system? In the muscle, it causes flaccid paralysis. Order of the muscles affected. So when we are using this order of the muscle is important, because with this we are using, for example, anesthesia. So when we are giving the anesthesia, some muscles are affected first. Again, when the patient is regaining consciousness from the anesthesia, some muscles are regaining their activity earlier than the other muscles, and by seeing this we can see that whether the patient is getting out of anesthesia well or not. So if there is problem of the getting out of anesthesia, so we have to use some drugs. For example, in these cases we have to use the neostigmine. So extrinsic eye muscles and muscles of the finger, these two muscles are the first affected. So usually these two muscles are usually checked while we are giving the anesthesia, to check whether the patient is anesthetized, and after the operation whether the patient is coming out of anesthesia. So the thumb muscles are usually seen and the extraocular muscles are usually seen, because they are affected first, and again they are regaining their activity first. And then the other muscles like neck muscle, face, hands, feet, trunk, and at the last, when the very high concentration, very high dose of this muscle relaxants are given, respiratory muscle paralysis can also happen, diaphragmatic paralysis can also happen, and the patient can die also. So this may happen when there is very high concentration of the drug is given. Recovery in the reverse order, when what I am telling, consciousness, appreciation of pain is usually not affected with this. Now their actions. These different drugs, some have some ganglionic blocking actions. So autonomic ganglion blocking property. The d-tubocurarine, which is the first muscle relaxant, usually they have more ganglionic blocking properties than the newer ones. When the ganglion blocking happens, ganglion blocking occurs, usually there occurs different types of the adverse effects, because the ganglions are blocked, all the sympathetic activity will be blocked. Histamine release, again it is done by very many agents. D-tubocurarine causes high histamine release. So allergy or anaphylaxis can also occur. The newer agents causes less histamine release. In the cardiovascular system, it causes significant fall in blood pressure. Increase in heart rate happens due to vagal blockade. Vagal ganglionic blockade, the same thing. Newer competitive blockers have negligible effect on blood pressure and heart rate. So what happens? The older ones have more activity on other agents, like they are also blocking somewhat to the ganglion, they are blocking they are releasing histamine from the muscles. So there are different types of the adverse effects. Most of these adverse effects are on the heart or the blood vessels. There will be sudden decrease of the blood pressure, there may be increase of the heart rate, and these adverse effects are less with the newer agents. So the adverse effects, same thing, hypotension, since there is decrease of the blood pressure, tachycardia due to vagal blockade, respiratory paralysis may happen, very high concentration of the drug, bronchospasm due to the histamine release, aspiration of gastric contents, this may happen because the muscles will be relaxed. So there will always chance of the aspiration. Aspiration means when in the operation the gastric juice goes within the respiratory tube, that is in the trachea. So this is known as the aspiration of the gastric contents. This is a very grave phenomenon during the operations. So it may happen, the chance will be increased because the muscles are paralyzed. Okay. So the newer agents causes less histamine release, do not block the autonomic ganglia, spontaneous recovery with most of the drugs, rapacuronium and rocuronium have rapid onset of action, atracurium is a agent that causes a different types of the elimination protocol. This is known as the Hofmann degradation or Hofmann elimination. So they are rearranging their molecules so that there will be inactive molecules generated from the atracurium after their action is gone. So this is known as the Hofmann degradation and Hofmann elimination. Mivacurium is the shortest acting neuromuscular blocker. So it is used as an adjunct to general anesthesia for producing satisfactory skeletal muscle relaxation. For facilitatracheal intubation, very commonly used. Rocuronium is preferred due to rapid onset of action. Succinylcholine will come to the latter. It is better due to short lasting duration. Now coming individual agents, pancuronium. Pancuronium is a neuromuscular blocker, competitive neuromuscular blocker, non-depolarizing blocker, which is a long acting. It is a synthetic steroidal compound 5 times more potent and longer acting than the d-tubocurarine. D-tubocurarine is the parent drug. That's why we are comparing all with this. It provides good cardiovascular stability, that is little ganglionic blockade. So ganglionic blockade is very less. Seldom induces flushing, bronchospasm or cardiac arrhythmia, so the histamine release is also less. Rapid IV injection may cause rise in blood pressure and tachycardia due to vagal blockade and noradrenaline release. That's why slow IV injection is to be given with the pancuronium. It is primarily eliminated by the renal excretion. That's why it cannot be used when the renal kidney is compromised in chronic kidney disease. Because of the longer duration of action, it needing reversal, its use is now restricted to prolonged operation, especially neurosurgery. So it is a very long duration of action. So if we are using this with a short surgery or short procedure, the patient will not regain their muscle relaxation property for long period of the time. That will be problem because that gastric aspiration and other problems can happen. So basically this is used in long duration surgery, most commonly neurosurgery, pancuronium. Atracurium is a bis-quaternary competitive blocker. It is 4 times less potent than pancuronium and shorter acting. Reversal is mostly not required. So atracurium reversal is not required. The unique feature is inactivation in plasma by spontaneous non-enzymatic degradation. This is very important because it is quite often asked that Hofmann degradation happens with the which drug? This is the atracurium. So Hofmann degradation and Hofmann elimination is a process of elimination where some spontaneous enzymatic degradation happens, this in addition to that by the cholinesterases. So ultimately duration of action is not altered in patients with hepatic or renal insufficiency or hypodynamic circulation. So atracurium or cisatracurium, it is congener. This can be used when the kidney or liver is compromised. For example, the patient is scheduled for surgery and the patient has some chronic kidney disease or chronic hepatic disease. So we can use this atracurium because atracurium is not eliminated through the liver, through the kidney, or it is not metabolized in the liver. Mostly it is eliminated by a spontaneous enzymatic degradation. Spontaneous, that is within its own, without help of any external agent. This is known as the Hofmann elimination or Hofmann degradation. Apart from this, it is also metabolized somehow with the cholinesterases. Rocuronium is a newer non-depolarizing or competitive blocker with a rapid onset and intermediate duration of action, which can be used as alternative to Succinylcholine for tracheal intubation without a disadvantage of depolarizing block and cardiovascular changes. So Succinylcholine will come to this later, usually commonly used. Apart from Succinylcholine, Rocuronium now it is gaining more and more usage in case of the endotracheal intubation because it is very short acting, rapid onset. Onset of action is dose dependent. It also facilitates mechanical ventilation in intensive care units. So ventilation. So usually in ICU patients, when the patient is scheduled for the mechanical ventilation, again we have to relax the muscles, and in those cases rocuronium can be used. So this is the normal, usually acetylcholine acts and that depolarization, contraction, relaxation usually happens. Already we have discussed about this d-tubocurarine or the competitive blockers. Now we will discuss about the Succinylcholine. Succinylcholine is a depolarizing blocker or non-competitive blocker. What happens? This Succinylcholine acts like that of the acetylcholine. It also comes within this NM receptor. Its affinity is also more than the acetylcholine, and it has intrinsic activity, but the intrinsic activity is the submaximal, okay, submaximal or subtherapeutic intrinsic activity. It is a long slender molecule. That's why when it is attached, there will be conformational change and sodium propagation happens, but this succinylcholine causes persistent depolarization. So you know that for the contraction there will be a cycle of the depolarization and repolarization. Always a cycle is needed. So when we are using succinylcholine, that attaches with the NM receptors, they have affinity and submaximal intrinsic activity. They cannot allow the acetylcholine to attach there, but it causes depolarization, but that depolarization is the sustained depolarization. It also causes conformational change. It is a long slender molecule. This is also known as the leptocurarine. That's why Bovet is a scientist who have coined the term. The previous ones known as the pachycurarine. It's a large bulky molecule, and this succinylcholine or other depolarizing blockers are the long slender molecules. These are known as the leptocurarine, L-E-P-T-O, lepto, and that is the P-A-C-H-Y, pachycurarine, leptocurarine. So ultimately this causes persistent depolarization. So when succinylcholine is given, there will be some initial contraction. So initial contraction, after that there will be prolonged muscle relaxation. Okay. So depolarizing blocker, just remember succinylcholine is only drug that comes under the depolarizing blocker. When the succinylcholine used, there will be two phases of the block, phase 1 and phase 2. Phase 1 is the classic depolarizing block, what I am discussing, again I am coming. They causes brief and quick muscle relaxation, genetic variability in metabolism is there, and malignant hyperthermia and hyperkalemia are the problems with the succinylcholine. So this is the succinylcholine molecules. So two molecules of the acetylcholine are basically attached, and ultimately this succinylcholine is generated. They have affinity and submaximal intrinsic activity, what I am discussing. They depolarizing muscle end plates by opening sodium channels. Long and slender molecule causes conformational change. Longer lasting depolarization of the muscle end plate produces repetitive excitation of the fiber. Okay, longer lasting, the same thing. It do not dissociate from the receptor and are not hydrolyzed by the acetylcholine esterases. So the competitive blockers can be reversed by the neostigmine, but the succinylcholine cannot be reversed by the neostigmine. So remember this. They induce prolonged partial depolarization of the region around muscle end plate. Prolonged partial depolarization. So sodium channels ultimately gets inactivated because the transmembrane potential drops to about -50 millivolt. Acetylcholine released from the motor nerve ending is unable to generate propagated muscle action potential, and flaccid paralysis in mammals happens. So this is somewhat different with the competitive blockers. This is because they are causing the depolarization, that's why it is known as the depolarizing blockade. But they causes prolonged depolarization, prolonged partial depolarization, that's why the end result will be the similar. The end result is the flaccid paralysis with both the competitive as well as the depolarizing blocker. In many species in slow contracting muscles and under certain conditions in man, when these depolarizing agents are injected in high dose or infused continuously, then they produce dual mechanism of neuromuscular blockade, and which can be divided into two phases. So when this succinylcholine is given in high doses, or in some of the cases, for example, when it is given in neonates or children, when it is given in some conditions where the potassium level is already high, for example in burns or in hypovolemic state, or if there is chronic kidney disease, or if in any other conditions of the hyperkalemia, in those cases succinylcholine level becomes very high and they causes dual blockade. Phase 1 block is already we have discussed the classic depolarizing block, and phase 2 block is more like the competitive blockade, the previous ones. So phase 1 block, it is rapid in onset, results from persistent depolarization of the muscle end plate, and has features of the classic depolarization blockade. That is what we have discussed now. This is the phase 1 block. This depolarization declines shortly afterwards, and repolarization occurs gradually despite continued presence of the drug at the receptor. So it is normally ultimately succinylcholine ultimately degraded, and normally the regaining of the muscle properties again comes back. But neuromuscular transmission is not restored if it is given in high doses or in those conditions what I am discussing. In those cases, phase 2 block supervenes. So phase 2 block is slow in onset, results from desensitization of the receptor to acetylcholine. So that means that the receptors, due to the prolonged or very high amount of the succinylcholine in the NM receptors, the neuromuscular NM receptors becomes insensitive to the acetylcholine. So that's why even if the succinylcholine is degraded to some extent, more acetylcholine is there, that acetylcholine can attach with the NM receptor, but they cannot sensitize the NM receptor because there will be insensitivity to the acetylcholine due to the prolonged and very high concentration of the succinylcholine beforehand. So this is the phase 2 block. The muscle membrane is nearly repolarized, recovery is slow, contraction is not sustained during tetanic stimulation. That is, here also fade occurs. So here the property is more like the competitive blockers, the previous ones. The block is partially reversed by anticholinesterases. Since it is more like the competitive blocker, so competitive blockers are reversed or surmountable by the anticholinesterases like neostigmine. So this can also be done by the neostigmine to some extent. In man and fast contracting muscle like tibialis anterior of cat, normally only phase 1 block is seen. Normally phase 1 block is seen, but in those conditions what I have discussed, in those cases phase 2 block can happen. So the same thing, phase 2 block may be seen in man when succinylcholine is injected in high dose, very high concentration, or infused continuously. Particularly fluorinated anesthetics have been used. So some anesthetics have drug interactions and the metabolism is compromised and more succinylcholine is available. Succinylcholine readily produces phase 2 block in patients with atypical and deficient pseudocholinesterase. This is another thing. So there are genetic conditions known as the deficient or atypical pseudocholinesterase or butyryl cholinesterase. So this cholinesterase ultimately, yes, okay, this cholinesterase ultimately metabolizes the acetylcholine. They also metabolizes the succinylcholine also. So in some persons, this pseudocholinesterase or butyryl cholinesterase is deficient. Or in some patients, some individuals, there will be some atypical pseudocholinesterase present. In those cases, that pseudocholinesterase cannot metabolize the succinylcholine. In those cases, there will be more availability of the succinylcholine in the neuromuscular junction. So ultimately, phase 2 block happens. And phase 2 block is dangerous because phase 1 block is common. So if we cannot predict this, if the succinylcholine level is very high, so there may be phase 2 block and there may be potential of some problems. So the phase 1 block, phase 2 block, the same thing. So phase 1 block, membrane depolarizes, resulting in an initial discharge that produce transient fasciculation. So since they are depolarizing block, so they are depolarizing. So some muscle contraction happens when we are using succinylcholine first. This is known as the fasciculation. So some sustained contraction, fasciculation happens, after that muscle relaxation happens. After that flaccid paralysis happens. In phase 2 block, membrane repolarizes, but receptor is desensitized to the effect of the acetylcholine. Okay. So succinylcholine is the most commonly used muscle relaxant for passing tracheal tube, endotracheal intubation. This is very common procedure you will see in the OT, in the ICU, etc. In those cases, we have to relax the muscles for the intubation in the trachea. In these cases, most of the cases, succinylcholine is used. But now newer agents like rocuronium, already we have discussed, the competitive blocker, lesser adverse effect are also used now. It induces rapid, complete and predictable paralysis with spontaneous recovery in approximately 5 minutes. So predictable, so we can predict in how many minutes it will again regain back. But when the phase 2 block happens, this prediction will be undone. So prediction cannot be done. Excellent intubating conditions like relaxed jaw, vocal cords are apart. So when we are doing endotracheal intubation, there are different types of the gradings of whether the vocal cords are apart or not. There are different apertures are seen or not. This is known as the Mallampati grading. Okay. So when we are using this muscle relaxant, the Mallampati grading will be more favorable for the intubation. It should be avoided in younger children, what I am telling, unless absolutely necessary, because risks of hyperkalemia and cardiac arrhythmia and also phase 2 block happens in the younger children. Risk of regurgitation and aspiration of the gastric contents is increased by succinylcholine in GERD patients. So gastroesophageal reflux disease. So those patients who have reflux, so there is always chances of the aspiration of the gastric content within the trachea. So that will be one problematic. And also in the obese patients, if the stomach is full. So in all of those cases, gastric aspiration happens when the stomach is full. That's why in operations, usually the empty stomach is usually needed, empty stomach. So overnight empty stomach is usually needed. Small rapidly moving muscles like eye, jaw, larynx relax before those of the limbs and trunks. The similar thing, the extraocular muscles and the thumb muscles. Ultimately intercostals and finally diaphragmatic paralysis occurs. Respiratory paralysis can also occur. Muscle relaxation, the same thing. This is the same thing like that of the competitive blockers. Details is not required. Uses, usually succinylcholine is employed for brief procedures, what I am discussing, most commonly for endotracheal intubation. Apart from this, laryngoscopy, bronchoscopy, esophagoscopy, reduction of the fractures, so fracture reductions, dislocations, if there is dislocations, to treat laryngospasm, rapid endotracheal intubation during induction of the anesthesia. So we are inducing the anesthesia, muscle relaxation is needed, succinylcholine is used. Occasionally it is used by continuous IV infusion for producing controlled muscle relaxation of longer duration in some of the cases. During electroconvulsive therapy, shock therapy, যেটা psychiatric patient দেয়া হয় এখন খুব কম দেয়া হয়, to prevent injury, usually succinylcholine is used. Adverse effects, transient increase in intraocular tension. So intraocular tension may be transiently increased. That may happen. Hyperkalemia is the most common adverse effect of the succinylcholine. So fasciculations release potassium in blood. Since there is initial muscle contractions, initial irregular muscle contractions due to depolarization, there will be more potassium release from the cells, and that's why the hyperkalemia happens. So when there is hyperkalemia, there is always chances of the cardiac arrhythmia and other problems also. Succinylcholine apnea can happen. So there may be sudden stoppage of the respiration may happen. Malignant hyperthermia. So the temperature may be very much increased when it is used with halothane in general anesthesia, because halothane also causes malignant hyperthermia. Usually the treatment is rapid cooling of the patients and the dantrolene. In the first I have said about the dantrolene, this dantrolene IV. So dantrolene is now the drug of choice for the malignant hyperthermia. So malignant hyperthermia is a condition, usually it happens with some drugs. For example, with the succinylcholine, we have to use the dantrolene, and some muscle pain can also happen. So you can see this is the fading. You can see this is the muscle action potentials. So d-tubocurarine is a competitive neuromuscular blocker. When we are using this d-tubocurarine here, you can see there will be progressive decrease in the twitch response. Twitch response becomes the muscle contraction response. Now we are giving a tetanic stimulation. Tetanic stimulation means in a short span of time, some contraction, some pre-specified contracting stimuli are given more. Okay, so when the tetanic stimulation is given, it causes a sustained contraction, but it is very poorly sustained. That is very less, not very large. Okay, then it is followed by a post-tetanic potentiation. PTP is the post-tetanic potentiation. So you can see the twitch response is more. So there will be more contraction, post-tetanic potentiation. Now when we are using some neostigmine, anticholinesterase, so you can see neostigmine restores the twitch response. So after the post-tetanic potentiation, there will be again gradual lowering of the twitch response. Twitch response decrease means muscle becoming more relaxed. Now we are using the neostigmine. Neostigmine just reverses this. So ultimately again the muscle contraction happens. So it is increased. So it is clear, ultimately it happens. So when we are using now succinylcholine, the depolarizing blocker, because it is a depolarizing blocker, so it causes initial contractions. This is known as the fasciculation. That's why there is increased. So there is increased contraction. So after this there will be progressive block, so there will be decreased. So decreased of the contraction, decreased of the twitch response. Then some tetanic response is given, that is in a short span of time, some repeated stimulus is given that causes a sustained tetanus, that is sustained contraction of the muscles more than the competitive block. But after that there will be no post-tetanic potentiation, that is there will be no increase of the muscle contraction after this tetanic stimulation is over. Block is not reversed when the neostigmine is given. In fact, you can see there may be in some cases increase of the muscle there may be decrease of the muscle contraction in some of the cases. So neostigmine cannot reverse the muscle relaxation properties of the succinylcholine. Only it can reverse partially if the phase 2 blocks by the succinylcholine happens. So by this picture it is clear that how basically these two acts on the muscles by the twitch response. Okay. So if we can compare this, so competitive blocker causes competitive blockade, depolarizing causes persistent depolarization. This is just revision. It is a non-depolarizing block, this is a depolarizing block. Usually it is a single block, it is a dual block, phase 1, phase 2. Causes reverse blockade like neostigmine, it do not reverse. There will be initial fasciculations not present, but here the initial fasciculations or initial muscle contractions are present. Slow onset, long duration, usually it is rapid onset, short duration. It usually release histamine, it does not release histamine. Usually in the depolarizing blocker there will be more potassium release or hyperkalemia, usually here the hyperkalemia will not happen. Now coming to the clinical monitoring of the neuromuscular block. Again, when we are doing the anesthesia, we are seeing whether the patient is getting anesthetized. And when the patient is coming out of the anesthesia, we are seeing whether the patient is well, the patient is normally coming out of the anesthesia. So this can be tested by different types of the giving stimuli. So there are different protocols of the stimuli, details is not required. There are stimuli like double burst protocol, there are train of 4 protocol, etc. Of this, the train of 4 protocol you need to learn. Train of 4 means 4 supramaximal electrical stimuli are applied in 2 seconds. This is known as the 2 Hz, and contractions of the thumb muscles are usually it is given in the ulnar nerve, and the thumb muscle contractions are seen. The train of 4 ratio is obtained by dividing the strength of the 4th contraction by that of the first contraction. So 4 contractions is given. 4th contraction কতখানি হচ্ছে তার থেকে ফার্স্ট কন্ট্রাকশন কতখানি কন্ট্রাকশন হচ্ছে সেটাকে ডিভাইড করে রেশিও বার করা হয়। নরমাল কি হবে 1 হবে, মানে কোনটা কোনটা ডিফারেন্স হবে না। So in the untreated subjects all the 4 contractions remain equal and train of 4 ratio is 1. Now during partial competitive block, so we are coming this, so when there is no drug, the train of 4 ratio, so these are the contractions, the supramaximal twitches are given. Normal person there will be same thing, same type of the contraction happens. So when the competitive block is given, for example pancuronium, you can see there will be gradual decrease of this, gradual decrease of the twitch potential. So this is T1, T2, T3, T4. So we are just dividing this T4 by T1. Okay, so train of 4 protocol. But when we are giving the succinylcholine, usually the 4 there will be no changes of T1, T2, T3, T4, but you can see the size is decreased. So the contraction of the muscles is decreased. There will be very submaximal contraction of the muscles, but there will be no fading. So fading, this is known as the fading, already you have seen. So fading phenomenon is seen with the competitive blocker, but it is not seen with the depolarizing blocker. This is another. So contractile responses of the adductor pollicis muscle to transcutaneous ulnar nerve stimulation with train of 4 protocol. Usually it is given. This is another protocol, double burst stimulation protocol. Again the similar thing is given seen, but details is not required. So it is clear usually train of 4 দেখা হয় এবং train of 4 রেশিওটা কতখানি কমছে, মানে কতখানি কমছে দেখে বোঝা যায় যে পেশেন্ট কতখানি মাসল রিল্যাক্সেন্টের অ্যাকশন থেকে ক্রমশ বেরিয়ে আসছে। পরপর 4টে স্টিমুলাস দেওয়া হয়, অ্যানাস্থেসিয়াটাকে বার করতে হবে, তো পেশেন্টের অ্যানাস্থেসিয়া থেকে বেরোচ্ছে না, এটাই তো অ্যানাস্থেসিয়া সবথেকে টেনশন, মানে অ্যানাস্থেসাইজড হয়েই আছে, বা যাতে বেরোচ্ছে কিনা ওটা দেখার জন্য স্টিমুলাস দেওয়া হয়। স্টিমুলাস দিয়ে রেশিওটা দেখা হয়, রেশিওটা যদি ক্রমশ কমতে থাকে তার মানে বেরিয়ে আসবে। এবার যদি কমছে না, সাকসিনাইলকোলিনের ক্ষেত্রে কম হবে অ্যাকশন পটেনশিয়াল বোঝা যায়, যদি না হয় তখন আমাদের অন্য মেজার নিতে হবে, নয় নিওস্টিগমাইন দিতে হবে বা অন্য কিছু মেজার নিতে হবে। ড্রাগ ইন্টারাকশনস আর দেয়ার, অ্যান্টিকোলিনেস্টেরয়েডস, নিওস্টিগমাইন রিভার্স দ্য অ্যাকশন, অলরেডি উই হ্যাভ seen. Apart from this, some antibiotics like aminoglycoside, some anesthetic agent like halothane, calcium channel blocker, that can also enhance the neuromuscular blocker. Okay, and halothane, if it is used with the depolarizing blocker like succinylcholine, that can cause malignant hyperthermia. Now coming to the directly acting muscle relaxant, dantrolene. In the first, we have discussed about the dantrolene. Dantrolene is directly acting. So they are basically acting on the ryanodine calcium channels. So RYR1 is the ryanodine receptor. These calcium channels are present on the sarcoplasmic reticulum of the skeletal muscles. But usually it does not affect the heart or other muscles, heart or other smooth muscles, because in those muscles there will be ryanodine 2 receptor is present. Okay, so ryanodine 1 receptor is present in the skeletal muscle sarcoplasmic reticulum. Usually you know about the calcium is, again it is needed for the muscle contraction, and when this when the calcium comes, they attaches with the ryanodine receptor and calcium induced calcium release happens, and ultimately this cycle continues. So when this dantrolene is given, it attaches with this ryanodine 1 receptor and prevents this calcium induced calcium release. So the calcium release is prevented. Intracellular release of the calcium needed for this excitation contraction coupling is interfered with. So they basically acts on the excitation contraction coupling portion of the muscle contraction. So fast contracting twitch muscles are affected more than the slow contracting anti-gravity muscles, and this is the drug of choice in the malignant hyperthermia. Again, this is an important question often asked, that what is the drug of choice for malignant hyperthermia? Dantrolene. Dantrolene acts on which receptor? Ryanodine 2 receptor. Ryanodine 2 receptor present on what? On the sarcoplasmic reticulum of the skeletal muscles. Why it is not acting on the heart or other smooth muscles? Because in those cases ryanodine 2 receptor is present. Okay. Muscular weakness is the dose limiting side effect. Troublesome diarrhea is another problem. So with dantrolene there may be diarrhea. Long term usually causes dose dependent serious liver toxicity. So these are the 2 adverse effects, troublesome diarrhea and some liver problems that may happen with the dantrolene. Ganglion blockers, there are some competitive blockers and some persistent depolarizing blocker. Competitive blockers are the hexametonium, trimetaphan and methyl mecamylamine. Of this, hexametonium can be used, and persistent depolarizing ganglion blocker are the nicotine in large doses. So in some of the spastic conditions, these drugs can be used. So these are the actions and the adverse effects of the ganglion blocker. So they are blocking the ganglions. So dominant in which organ, what is the dominant ganglion? Accordingly, the actions of these ganglion blockers are seen. For example, in heart, you know the dominant autonomic nervous system is the parasympathetic. So if we are blocking this ganglion, that causes tachycardia and the patient presents with palpitation. If the blood vessels, the dominant is the sympathetic. So there will be vasodilation. So the patient comes with hypotension, that is dizziness. In the iris, again the parasympathetic, so mydriasis. So mydriasis means the pupil will becomes larger, so there may be photophobia. So in the sunlight, the patient will be uncomfortable. Ciliary muscles, again parasympathetic, there will be cyclopegia, that is blurring of the vision. Intestine, again the parasympathetic in the main, so this is blocked, so motility is decreased, so constipation can happen. In the bladder, again the parasympathetic tone is the main one, dominant one, so there will be decreased tone of the bladder, so again difficulty in micturition occurs, so urination becomes problematic. Male sexual function, again the parasympathetic is the main thing, again so inhibition of the erection and ejaculation both can happen and impotence can happen. In the salivary gland, again parasympathetic, dry mouth, difficulty in swallowing can happen. In the sweat glands, inhibition of the sweating can happen. So this is also important for your ANS chapter, because you need to learn about what is the dominant ganglion in different organs, and accordingly if we are blocking the ganglions there, what are the dominant actions in those organs. Okay. Lastly, the centrally acting muscle relaxants. Already we have seen the centrally acting muscle relaxants mainly acts in the cerebrospinal axis. They are used in different neurological spastic conditions. They without alters the consciousness, they selectively depress spinal and supraspinal polysynaptic reflexes. So there are different spinal reflex, polyspinal reflex. These reflexes are basically decreased. These are the different agents. Remember the name baclofen. Baclofen is also available as the oral as well as the intravenous form. This is the analog of the inhibitory neurotransmitter GABA, gamma aminobutyric acid, acts as a selective GABA B receptor agonist. So this is a selective GABA A, GABA B, there are two GABA is there. You will learn about this GABA later in benzodiazepines chapter. So this is GABA B receptor agonist, acts in the spinal cord, depresses both polysynaptic, monosynaptic reflexes. It is used where there is spasticity in different neurological conditions like multiple sclerosis, amyotrophic lateral sclerosis, spinal injuries, flexospasms. Baclofen is also used in wry neck or torticollis if there is severe muscle spasm in the neck. Tizanidine is another. This is a clonidine congener. Clonidine, you know, is a alpha-2 adrenergic agonist. So this is a congener of this. They also facilitate different inhibitory neurotransmitters like GABA and glycine, mainly glycines. Different reflexes, polysynaptic reflexes are inhibited. Again, it is used in different neurological conditions. So side effects are dry mouth, drowsiness, etc. So basically all these centrally acting muscle relaxants augments the inhibitory neurotransmitter. So inhibitory neurotransmitter commons are the GABA and the glycine. So they are potentiating GABA and glycine so that the centrally acting muscles, skeletal muscles will be relaxed. So it is used. Apart from this, there is several others. For example, details is not required, just remember the name. Like thiocolchicoside is there, very commonly used. Thiocolchicoside, you can see it is usually commonly used in combination with the acetylcholine. So acetylcholine thiocolchicoside combination is there, mainly used if there is severe backache or severe pain in the neck. In those cases, there is some component of the spasm associated with algesia. So we need the analgesic with muscle relaxant property. That's why these two are combined. So it is used in acute muscle spasms. Torticollis means sudden contractions of the neck muscles. Lumbago, again in the lumbar muscles. Backache, neuralgias, anxiety and tension in some of the cases. Spastic neurological diseases, amyotrophic lateral sclerosis, multiple sclerosis. Tetanus. Tetanus can happen, you know, if there is any accident and if there is the tetanus spore goes inside and anti-tetanus vaccine is not taken. So tetanus, sustained contraction of the muscles. In those cases, it is usually used. Electroconvulsive therapy, ECT, when it is given, and orthopedic manipulations. Again, the centrally acting muscle relaxants are used. So thank you. So this is all about the skeletal muscle relaxants. I hope you have understood this because this is one of the most complex chapters in the whole of the pharmacology. I have tried to simplify it, and if you have heard my class attentively and just read this in the evening, it will be clear. So the main thing you have to learn about the names of the skeletal muscle relaxants. Next, the mechanism of action of the competitive blockers and the non-competitive or depolarizing blockers, and what are their difference. If the mechanism of action is clear, everything will be clear. Next, where it is used, the indications of the skeletal muscle relaxants, name where the dantrolene, where it is used, what the centrally acting muscle relaxant names and where it is used. Okay, and how when some concept about the train of 4 protocol. If you are very good at the Viva, then this train of 4 protocol can be asked. So it is clear. Any questions? Kono question থাকলে এখনই clear করে নে, কারণ this is one of the complex chapter. Okay, কোনো doubts রয়েছে? ঠিক আছে, ভালো করে পড়, কোনো doubts থাকলে পরে বলিস, next week আসবো. Okay, thank you.